Today, we're going to talk about IVF and getting a second opinion. So many people ask me about second opinions. They tell me that they're so confused about things like PCOS, some of the new technologies, lifestyle habits, IVF questions, and so much more. So today, we're going to dive into some of these topics so you can get answers to your questions. I've invited Dr. Steven Palter, who's an influencer and also a terrific doctor, to help us understand some of these very confusing topics so that you can either take it to a second opinion or you can bring it to your doctor. Let's roll the tape. From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. Welcome to a new episode of the Building Your Family podcast. I am so delighted to have you here today. We're going to talk about something that's really important if you're pursuing treatment the unconventional way, because so many people struggle with, should I get a second opinion? Should I not get a second opinion? What should I do? And there's so many topics to really think about because there's so much confusion out there on the internet and so much misinformation. So we are going to cut through all of that today with Dr. Steven Palter. He is the medical director, scientific director, and founder of Gold Coast IVF here in New York. And I'm so happy to have him here today because not only is he an influencer, but he is a voice of reason, and he's going to share answers to our most pressing questions. Thank you for coming, Dr. Palter.
Thank you so much for having me, Lisa. It's great and honor to be here with you again. And we've talked for a while about coming here and kind of trying to give some guidance to people as they try and navigate this path through fertility.
Yes. And you are so good at that. I love watching you on social media, and you really help so many people get the right answers to so many problems. I think it's wonderful. I don't know how you have time for it.
I said I'm an accidental influencer. I didn't start out to do this. I had educated physicians for years. That's what I was doing. I was running large seminars for fertility doctors to teach about innovation. So one of the things that I've always done is been at the forefront of new treatments as they come out, trying to figure out, what do we start doing? How do we launch this into practice? What's reasonable? When does the hype match the reality? I was on the full-time faculty at Yale. I was the clinic chief of infertility. And then when I came back and founded the program in New York, when I was here, Fertility and Sterility from ASRM asked me to be their editor for all media. And what I said was I wanted to change how doctors learned. The old idea of reading an article in isolation and picking it apart and then trying to figure it out didn't meet the modern world. So we live in this interactive world of endless information. It used to be the challenge for doctors and patients was to get the nugget of information. But now there's a fire hose of information, and the challenge is, how do you process it and sort it and figuring out how do you apply it to what you do, especially since so much of it seems contradictory. And at the same time, patients were coming to me in my practice in New York, and sometimes they were doing things that just seemed bizarre. And I would say, where did you learn about? Like, why are you doing? We told you to do this and you're doing this other thing. And they'd say, well, I follow this influencer online who told me to do this thing and sold me this program. And then a few of them were really big accounts themselves. And they said to me, you should do this. You should do this online for patients.
Wow.
And I said, but isn't that just like, I don't dance. I don't have long hair. I'm not cute. I'm not young. I'm not skinny. And they said, no, like, social media can be a tool for education. So what I did was made a list of the things where I thought patients were confused, or where practitioners may have gone down the wrong path, or something new came out and they didn't know how to apply it. Or when I saw second opinions, what was the thing that I saw getting missed over and over? And I said, how could I help more people than I could be seeing? And then what blew me away was how in 60 seconds you could give a bit of information to someone, they could get pregnant from that. They could either change what they're doing or go to their doctor and say, I was always thinking about this. Have you thought about this? Or check something different, which is kind of like distilling down the essence of what you'd pick up in a second opinion to make a change in someone. I call it a solution influencer because I provide solutions to problems. And my content that's been the most resonant to people is the ones that explain something new or helps them solve a problem that they couldn't solve.
That's fantastic.
Most of the platforms now have over 600,000 followers and 650 million views of the videos, up to a million video views a day.
Oh my
And the
gosh.
difference is that my content has enormous engagement of people asking questions and getting answers. What about this? That's what just I find so remarkable about the online community.
It's so great that you're helping so many people. So, to that end, I would love to give our audience today some of those solutions. Why don't we start with one of the things that you've worked on for some time? It sounds like PCOS, which we've covered a little bit here already, but I'd love to hear your perspective or prescription for patients.
PCOS is one of my passions. We have a fully dedicated, actually online remote program to help
Oh,
people overcome it. And it actually came out of years of work and then became something new because of the online work. So PCOS is now the number one hormonal disorder of women. It affects 15% of women, and it's the number one cause of infertility in the US now. This used to
wow.
be when I started, years ago, this was 5% of women, then 10%. Now it's 15% of the entire population. And it is the number one cause of infertility. And as PCOS goes up, infertility is going up as well. There is a shared pathophysiology, a disease process of it that responds to women's lifestyles and the toxic environment we're in. So you don't hear about endometriosis going up. You don't hear about the rate of male factor increasing. Like nothing tracks the way PCOS has gone up. And what's different about it is it is not just a reproductive disorder of getting pregnant, but it affects the hormonal cycle of these women throughout their entire life. From when they're teenagers to reproductive age to in the menopausal years, it affects every body system. And when you understand how it works, you understand more about how it causes so much disease. And so in the early years, these young women have irregular cycles. They don't get a period, and all of a sudden they'll hemorrhage. Then they have excess facial hair and acne. And so they not comfortable with their appearance at such a vulnerable time in their life.
Yeah,
80% of them are overweight, but 20% of people with PCOS are still
right.
thin. So in those early years, you've got excess facial hair, acne, irregular periods, and obesity. Then you go to get pregnant and you can't get pregnant and your cycles are irregular, so you don't even know when to try. And then these women, the health risk is just so underreported from it. They have enormous lifetime risks of diabetes, high blood pressure, endometrial cancer, even Alzheimer's.
Yeah, and heart disease, right?
And so we now understand it's all related to the root cause of PCOS in so much women, which is a metabolic illness. And so I call PCOS now diabetes of the ovary because that's basically what it is. There are many things that can cause it. There's genetic predispositions, and there are things with the way the hormones work in some of these women that makes them predisposed. But the insulin resistance, meaning that when you make blood sugar, insulin is supposed to lower it, and your body starts needing more and more insulin to keep your blood sugar normal. And that's what would be called prediabetes if you were a 50-year-old man. But
Mhm.
in a woman, that high insulin level leads to inflammation and it leads to driving the ovary to start making more male hormones, which sets up this vicious circle. And so, this underlying metabolic dysfunction is at the root of much of the systemic illness. And what happens is, if that woman is in a perfect environment, where she's eating perfectly and exercising perfectly, it can be tamped down. But our modern American diet is so dysfunctional and so toxic. Look around you. I mean, 50% of the population is obese, childhood obesity. They're telling kids to be on Ozempic because they're so overweight. A
Mhm.
diabetes epidemic, heart disease epidemic. So they're all from insulin resistance.
Yes.
And if you look at, well, the same thing, if we've plotted the line, the same thing happens in PCOS from our toxic environment. It was a survival gene that started. A lot of people don't realize that. Like in
Mhm.
times of famine, insulin resistance and being able to hold weight and have this would allow you to survive. But when we have this processed foods, and overnutrition and over calories stuffed with high carbohydrates, the insulin levels skyrocket and it drives all these metabolic and hormonal abnormalities. And it just sets up this vicious circle. That's sort of what PCOS is. Years ago, I had met, God, it must have been in the 90s, Atkins. Remember the Atkins diet?
Yes, yes.
So I had met Dr. Atkins and they were talking about this. And I was a resident at the time. And I was saying, I wonder if this would work for PCOS. And we had tried it in some PCOS people, like back then in the clinics where I was working, and the hospital said, like, you can't do this. Like, you can't use these like, they'll get a heart attack and die. And then when I was at Yale, the keto diets and the low carb diets came out. And again, I wanted to do it, but it was people didn't understand how it reset the metabolism. So fast forward years later, I'm doing IVF and IUI, and we figured out that it's not just keto diets, not just low carb, that people can actually reverse insulin resistance and even reverse diabetes. The American Diabetes Association always said that diabetes is a lifelong disorder. So they came out now, and there are people that in 6 to 8 weeks are getting off insulin. So I learned from them and then applied it to what I knew about hormones, where the end point isn't your blood sugar and your insulin, it's fixing your hormones. The problem is, I always say, you can tell when a woman with PCOS has a skinny doctor, because what they told them was, lose 10% of your body weight, eat less, move more, and come back when you lose 50 pounds. Oh yeah.
Right. So easy.
Yeah. Just come back. Just do that and come back.
Yeah. And that doesn't help the skinny PCOS patients.
Right. But like, no one knows how to do that. Like, yeah, fine. Like, what does that mean? How can I just go and do that? These women have tried every diet under the sun. They starve themselves. They're eating salad and running on the treadmill for hours a day, and it's not working. And so we developed a specific protocol that actually targets the hormonal endpoint of being ovulation. And with it, reducing the inflammation, reducing the cortisol, reducing the male hormones with very specific dietary interventions that are different than, it's based on what you would do with diabetes reversal, but modified. And so I was doing this with my patients, and we started getting people coming for second opinions. And while they were prepping for IVF, they would get pregnant on their own. And then I was teaching this in my videos online, like tidbits of it, trying to condense, like, how could you condense a 6-week program into just little nuggets, but one after another, people are getting pregnant. And then they said, could you just put this together for something that we could do remotely? And I had never done it because it's so time intensive and it's so labor intensive to coach people to know how to execute. So the information isn't the barrier. It's actually coaching them of where they're failing, like what you think you know and it's not working. You need a coach, you need a guide, you need actually a protocol, and you need feedback. We put glucose monitors on people. We measure their bloods. We have real-time feedback of exactly how their body's responding to what they do. And I said, well, if I can reach 1 million people a day online, now I have a large enough audience that I could put this thing together and have it be like less than the cost of coming for a consult. And we could guide you through 2 or 3 months and get you pregnant. And that's what became, we call it the PCOS to pregnancy protocol. And it's a freestanding program now where people go through it either on their own before they're trying to, when they're not in treatment, or if they're part of IVF and it hasn't worked, trying to reset their hormones.
That's fantastic. And does that include like weightlifting, strength training, that sort of thing?
So you think of it as like a tool belt. Okay. There's all these armamentariums you could use to target insulin resistance, inflammation, and male hormones. So the key of it, 75% is going to be the dietary basis. But we don't call it a diet. We don't call it exercise, because the mistake is what we showed in our initial cohort that went through this is you don't have to lose weight to actually ovulate with the PCOS. We have people where we put a 24-hour glucose monitor on them. We see their blood sugars drop to normal. We like 50 points in less than a month. They ovulate in 4 to 8 weeks, and then they start losing weight. So you have to change how you eat. You have to change how you move, but it's not necessarily exercise and diet. So when you talk about weightlifting, sure, resistance training is amazing, The muscle acts like a sponge for insulin and drops your blood sugar. It also reduces your appetite. So we start with the specific diets with the carbohydrate restriction, different than keto. We use way more protein. We measure it. The people who are doing blood tests, not everyone does. Some people don't do any testing. Some people do blood testing. We can tailor it to what they do. We then add exercise, but in tiny little bits, like trying to look at the first part is going to be like 5 to 10 minutes a day of just getting the muscles moving to act as a sponge. Like one of the tidbits is, this was in Italy, they've done this for decades.
Yes.
You, within 20 minutes of finishing dinner, if you go for a walk, that action, your heart rate doesn't even have to be up, just that muscle action will plummet your blood sugar. And a study just came out in the last couple of weeks that those people have a dramatically lower risk of heart disease, mainly from blood sugar, insulin, and inflammation.
It's
Just the
incredible.
order in which you eat your foods makes a
Yes.
difference. So if you eat fiber and non-carbohydrate protein fibers first, and then eat the carbohydrates, your blood sugar doesn't rise as much. So there's so many of these tactics that we use to guide people. But when you get online, like everyone makes it sound like, here's the answer. Okay,
Yes.
take this
Ozempic.
supplement.
Yeah.
And then next week, oh, just walk 20 minutes after you eat. And now don't eat this, but eat Greek yogurt. And so how can you process like these thousands of things? So what we did was we put it together into like a system where we guide you through it every day. There's 5 minutes of content. You do an assessment, 5 minutes, and you measure. And then you get real-time feedback. And we have coaches and groups that actually say, we know where you're going to fall off the wagon.
Wow.
Like you have a party, you're having this for breakfast, you ate this and now you're falling asleep, you got hidden carbs. So we know where people fall off and we can guide them to the success.
That's terrific. And do you also incorporate things like metformin and other more traditional PCOS treatments?
So if you're my patient, we'll do those things. So if you look at the drugs that are used, they're all insulin sensitizers. So
Yes.
metformin is used as an insulin sensitizer. Now, when you hear about the Ozempic babies, people on GLP-1s, the reason why those people got pregnant is that they had PCOS and they improved their insulin resistance or lost weight, and it triggered them to ovulate. So the goal of our program is it's a lifestyle program that you do before you're on medications, before you're doing anything else. That's one group of people. The next group, they're already in the middle of IVF or IUI where they may have got no blastocysts. They may have got no euploid embryos or their embryos aren't sticking. They'll do this as an adjuvant to it. If you want to go on drugs using metformin, Clomid, letrozole, then that's what I do with my patients in person. But the online thing is what you do on your own, basically. Like these aren't my patients. We're giving them the lifestyle interaction and the guidance to do this on their own or with their own doctor. And then if you want to come to see me as a patient, that's a completely different process. That's when we get into medications.
I see. So interesting.
Virtually no patient that I see do we need to put them on Ozempic or Mounjaro or Zepbound to get them to improve their insulin resistance or to get them to be able to do treatment. In fact, the diabetes reversal people found the same thing. If you properly guide someone with the proper dietary things, which can be combinations of tailored carbohydrate restriction, protein supplements, perhaps intermittent fasting, perhaps exercise, different in each woman, they have the same degree of weight loss as GLP-1s did without the
Wow.
medication. But it
Really?
required, the hardest part is needing the support. So a lot of people eat not because they're hungry.
Yes.
And so emotional eating, binge eating and guilt eating is huge in women with
Huge.
PCOS. The rates are up to 50%. When you eat a meal and then you crash afterwards and you feel like you're sleeping and starving, people say, my blood sugar's low and I got to eat. We put a glucose monitor on them. We show them, no, actually your blood sugar was spiking and then it dropped and you triggered this. So if you we change sort of how they eat, and we do scales on binge eating. We do scales on emotional eating. And we know, okay, here's your trigger. We get a profile. Here's your triggers. When that happens, we're going to do these things instead. And it makes a huge difference because knowing, like, listen, I can know not to eat the donuts,
Right.
but I'm having a stressful day and someone
It looks
brings
much,
it to me,
yeah.
and that's like your comfort food. Like, we had someone in the office said, like, "Oh, I'm eating my sadness," she said. And I said,
Yes.
"Right, that is an unhealthy reaction that's epidemic."
Mhm.
And so
Mhm.
you probably, I mean, being in the field, I mean, the rates of anxiety and depression in PCOS are astronomical.
Yes.
And I think it was very paternalistic. What our field had said for years is, well, look at these women. They're overweight and they have facial hair. They don't feel good about themselves and then they can't get pregnant. That's why they're anxious and depressed. Well, lo and behold, this whole world of data comes out in mental health research about insulin resistance and prediabetes, and they show they have massive rates of
Yes.
anxiety and depression. And when you fix the metabolic disturbance, they get better.
Yeah.
And we found the same thing. People who go through this type of transformation in what they're eating, they'll say in 1 month, oh my God, I feel like a different person. Like, I just don't feel that cloud. I don't feel as on edge. I just feel better. My
Yeah.
skin cleared up. And they're not anxious and depressed because they have an extra pound and they have some acne. This is a metabolically caused
Yes.
mental change. Treatment resistant depression, epilepsy. I mean, these things can be cured with dietary interventions in many, many people.
That's so interesting. And not to mention, the downstream effects, right? The gut microbiome and all the things that happen to us that affect our mood that we don't even realize until we change our diet.
It's astronomical. So, I mean, you look at the way people ate 50 years ago versus now, like our dietary guidelines, it's finally coming out that these are based on marketing and based on faulty science. It's very interesting. We say, do you know, like, if you take Nestle or all these big food companies, do you know where a lot of the food scientists got their training?
No.
They were in the cigarette industry.
Really?
They
Oh,
were in
because of
tobacco. They
addiction.
were in big tobacco. And when that legislation came out, they left, went to big food. And the idea was, how do we make food last forever where it doesn't spoil, is incredibly cheap, is very tasty and hyper palatable, and is addictive? So if you take a carbohydrate and a fat and salt and combine them, you can make a rat be addicted. And it lights up the same part of their brain that if they were using drugs.
Yep,
And so
absolutely.
this food is designed to be addictive. And then they say, well, listen, breakfast is the most important meal of the day. You got to get your heart healthy grains and you've got to get, 6 servings of this. And then you got to have 5 snacks during the day. So heart disease, diabetes, and obesity went through the roof, and so did PCOS. We're doing a disservice to an entire generation of people. Listen, I've used a lot of the interventions. Like, I learned them to get myself healthier initially. So I was never diabetic, but I had it in my family. I was really overweight. I learned these things. I learned at how they work. And then I said, okay, what's the hormonal effect and how is it different in a 30-year-old woman trying to get pregnant versus a 50-year-old man trying to lose weight? It's not the same, but it's the same root cause.
Same idea. That's fascinating, really fascinating. So you have this whole program in your practice, but through your website, people can find it?
So most of the people who are doing this are not doing it as part of our practice. They're doing it on their own. So you can get it online at PCOSbaby.com. We made a special Lisa 20 discount.
Oh, great.
You
Terrific.
enter Lisa
Great.
20, you get 20% off. I mean, it's less
Terrific.
expensive than trying to do a consult. And it's funny, a lot of fertility centers are starting to use it now. And they basically said they can't afford to do this kind of coaching for people because it's so labor intensive.
Yes.
They're getting measured by how many IVF cycles they do. I mean, that's
Right.
another discussion about,
Yeah.
our field has gotten where the metric is not how good you are for your patients, but how many cycles you do. And they say, listen, we can't do this stuff in our model. We got big enough on social media that we have a large enough audience that we could build this out as a program. And so it's PCOSbaby.com. You come on, you do it on your own, but then we have regular meetups. We have coaches and you get feedback from me and the whole group to get you to success.
Well, I hope everybody out there is listening because this is really important information. And I'm sure you've heard it in bits and pieces, but it's really, really important. And what Dr. Palter is saying here is going to really affect your whole life. I mean, changing your diet, changing your exercise, changing your habits is everything, right? We really see that.
It's interesting. A woman just wrote to us. She said for 8 years she was struggling. My father was a psychologist, and I asked him this once, and I said, why do people not take action? Like, why would you, like, we said, you have a money back guarantee. So, like, if you don't see improvement, we'll give you your money back. And I said, like, why would someone
not do it?
And what he would say to me is, they're afraid they're going to fail again. And these people, she said to me, 8 years I tried 3 IVFs that didn't work. And she said, and I knew I wasn't healthy, but I thought I had tried everything online. I tried all the supplements. We don't sell supplements. We don't sell anything extra. We just say, here's the core. We're going to educate you. It's like the same thing that I do with the social media. We're going to educate you. That's our service. And she said, I knew I was unhealthy. And I just saw so many people getting success. I said, what more do I have to lose? And she said, I knew if I tried it and it didn't work, there was nothing left. And she said, but I knew I had to try. And she said, so I took the leap, and thank God, in knock wood, she did it for, I think it was less than 6 weeks, got pregnant on her next cycle and is still pregnant. And so it's just, but these women they've been let down so many times, and they try to figure it out on their own in this sea of misinformation. Like, I could make videos all day long duetting people saying something that just makes no sense or is taken out of context. Like I always say, if you go see a doctor and every single person in the waiting room or that there has the exact same treatment and the exact same diagnosis and everyone's told it's unexplained, then you're following a protocol, not getting diagnosed. And so online, if anyone tells you, here is the supplement that fixes everyone to get pregnant, or just do this treatment of whatever, and that's the answer to everything. Infertility is like 1,000 different little pieces. And one size fits all answers from people usually are not people. Like, the more I learn, the more I say, well, maybe, but you say that over and over, like, let's try this. And the key is when something doesn't work, it's never just bad luck. This doesn't exist. There's a medical biological reason why things don't work. We may not be able to figure it out, but you always have to ask, what could I have missed? What diagnosis did I think you didn't have that got lost? Like, one of the biggest, so I have a series called Medical Mysteries. It's 5 seconds long. I put up a problem, a case history, and then I say, what's missed here? And that's probably 80 million views.
Wow.
Of those. Because I know these are things that I've seen 100 times. And by asking those questions, we get to a solution. So one big one is, if your fallopian tube is blocked and filled with fluid with scar tissue, that's called a hydrosalpinx.
Yes.
And that can make IVF half as likely to work or double the odds of miscarriage. So people will do an ultrasound or an x-ray, and they're often not read well by the person who did it. And then they go to another opinion, or it's done by a radiologist, and then they go to the fertility doctor, and in their chart, copied and pasted 100 times, normal tubes. So the first thing I do is I see the patient, they failed 5 times. I say, great, I need to see the x-ray and the ultrasound. I want to look at the pictures. There's the hydrosalpinx they missed day 1. And then they'll say, but every time I had an ultrasound, someone said, boy, there's this thing there, and there's a thing next to your uterus, but your tubes are normal. You don't have that. So you have to challenge your presumptions, challenge all the facts. Like, every time something doesn't work, what could have been missed? What can we reassess? What can we do differently? Like, I saw a woman from Florida. She had all the signs of PCOS, couldn't make normal embryos. And they kept telling her, you don't meet the diagnostic criteria. So we retested her. She did. She went through our program and got pregnant on her own.
Wow.
It's like, just because in the past, or you think you had a test, the test was never run, or the test was misinterpreted.
Yes.
If you said, like, listen, my car makes a noise, I went to the mechanic, they replaced the part and it didn't fix it. What would you say? You say the mechanic missed the part.
Yes,
But in
yes,
medicine, they assume that like because I had the test, the answers are there. And it's not that simple very often. Things change.
yes, 100%. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short term, but long term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. And I'm so glad you're talking about this, Dr. Palter, because patients often don't know what questions to ask, right? I often say when people make choices in treatment, whether it's going from IUI to IVF, IVF to donor conception or surrogacy, they don't know what questions to ask. They may choose their doctor because they like their website. They may choose a donor because a donor looks like Christy Brinkley, but Christy Brinkley's daughter looks like Billy Joel, right? So,
Right.
the genetics are much more important than what the donor looks like, right? So people don't really know what questions to ask. And I think that's why what you're saying is also so important that people get expert opinions from people who've seen it, right? Seen thousands of patients and understand this is what happens.
But there should be a dialogue also. Like no matter who you see anywhere in medicine, if you walk in, like someone who was like a really smart doctor that I started with when I first started, years later said to me, I've seen it all. They walk through the door and in 30 seconds, I know what treatment I'm doing. I said, you got burnt out and you closed your mind. So
Yeah.
the longer I practice, the more I see questions. And so
Hmm.
if you go see someone, there should be a discussion. Well, your history says this, this, this. What about these other 10 things? And what could we have missed that could be changing the outcome? What could we do differently? The other thing that gets me upset is sometimes places will change a protocol that is not expected even to work just to be saying to the patient,
I'm
I'm
doing
doing
something.
something different. So this
Yes.
woman, they'll come to me and say, oh, I went for a second opinion. I said, great. Go back and ask them, how many times has that worked in someone like you where this other one that makes sense didn't work? And they'll come back and said, oh yeah, they said they don't think it's going to work. It just was something different. So everything has to be founded in like logic. Like
Yes.
why are we making a change? Why are we doing this? Why did your treatment not
Hmm.
work? So that's what I teach online and that's what I do with my patients.
That's great. So, on that note, I wanted to ask you because I know you have some opinions about this, about genetic testing, but not just like your basic recessive carrier screening. We can talk about that. But I'd be curious to hear, first of all, what you think about using PGT-A for donor cycles, and then also introduce the audience a little bit to the PGT-P.
This has certainly been controversial. I mean, the PGTA has gone through ups and downs.
Yeah,
In a lot of it is platform dependent as part of the problem. So it's not a pure diagnostic test saying that this embryo is always good and it's like this one is
it's
more
black and
likely
white.
to be good.
Yeah.
This one's more likely to be better. And there's a gray zone, the mosaics in the middle that often can be very healthy embryos. So some of the labs were not reporting things. And when they read the DNA, some labs have much more detailed reads of the
Yes.
DNA than others do. So
Yes.
some of them you'll get no answer, or you'll get noise, or you'll get abnormalities that aren't truly real. And so it's very important what platforms used. Overall, the data said that for donors, it didn't improve the success rate, but that's because the majority of the embryos were normal in that age group. So it can be helpful, but a lot of people using donor probably will get pregnant without it. So very often we say if you want to limit the number of eggs you're using and maximize the number of children, this gives you the answer, but a large percent of them will be okay. There's even evidence that this is one of the things that let us learn that the lab conditions, we've got really sophisticated air purification. We were the first users of the Life Air system where we actually move all the VOCs in the air and have filtration for molds and viruses. The donor embryos, a donor egg, so there were egg banks that looked at when they did PGT, the euploid rate between labs. And
Hmm.
the same donor bank could have different euploid rates depending where their eggs were used. So it's not
Wow.
always that the egg is bad, but
The
how the egg
environment.
develops and the environment can induce it.
Wow.
Now, when you talk about PGT-P, which is called polygenics, this is something I've been talking about a lot. This is probably the hottest controversy in reproductive medicine now, and a lot of confusion and misinformation. So when we look at genetics, there's two major kinds of genetic screening that we do. So one is called carrier screening. That's where you look for a named disease where there's an error in like one letter in one gene and it leads to a known disease.
Hmm.
Tay-Sachs disease, sickle cell anemia, genetic deafness, those kinds of things that you've heard of, where there's one letter that's wrong and and you get that mainly from your parents. So you could have a form that comes just in that egg or sperm, but those are rare. Usually these are recessive disorders, meaning the male and the female both have to have it, and then the kid's at risk. So testing for that is called carrier screening, and the embryo screen with PGT-M. PGT-A looks for a random genetic error where a whole chromosome or part of it's knocked out, and these would be incompatible with life. That's the main one that's being done in most people who are doing genetic screening of embryos. Now, PGT-P is brand new. It's called polygenic screening. This is that there are many diseases, the major ones that people have: heart disease, breast cancer, colon cancer, prostate cancer, Alzheimer's, schizophrenia, alcohol dependence, ADHD, autism, where it's not one gene, it's groups of tens, if not hundreds of genes that contribute to that. Well, the genetics world has been working on this for a decade, and they have large banks of data where they have millions of people and they have their gene sequence. So over the years, they've been saying, let's figure out, can we see who's got more of a risk of Alzheimer's than someone else?
Hmm.
Who has a schizophrenia risk versus someone else?
Right.
And here you don't get a diagnosis, you get a risk score. So this person has a threefold increased risk of this disease. Well, they then said, well, if we can do this in an adult, why can't we screen two embryos and know that this one has 3 times the risk of schizophrenia than this one? The technology never existed. We couldn't do that kind of genetics on an embryo. Now we can. So we've been offering this for about 3 years for serious diseases like type 1 diabetes. There were only like 3 or 4 diseases that it could be done on, and the family had to have a pretty strong history. No, very few people wanted to do this. But just over the past few months, a few companies have come out that are doing this for much larger scale. So like the prostate cancer, breast cancer, colon cancer, schizophrenia, ADHD, and then they added in even some traits like height and IQ, which are super controversial, but let's focus on the diseases. The argument is on a lot of folds. One is not everyone in the field believes the science works, that you can predict which individual has
Reliably.
a higher and lower risk.
Hmm.
Many people don't yet believe that you can reliably test a little tiny embryo. This can be debated in science. The models work or they don't work. Then the next question is it ethical to do this and how much should you do it? So, I had family member that had severe Alzheimer's. I saw her wither away and die from this. And there are people I know who have had 3 or 4 people in their family have it. So
Hmm.
if you were doing IVF and you had 3 embryos that all looked good, and me and my embryologist are randomly picking one, or you could say this one has one third the risk of that one, a lot of people would choose to do that for their child. It's
Yes, of
like
course.
longevity before birth.
Yes.
And then there are some people that don't even have infertility. They're saying, listen, my mom had horrific schizophrenia. She was institutionalized. This is genetic.
Yeah.
If you could find this and dramatically reduce the risk in my child, I want to do that. So there's this huge debate now is one, is this ever ethical? So I think the ethical side, like, listen, if there's an illness and we're randomly picking embryos and science could tell us which one is healthier, how can sex selection be ethical and this not? Like, if you can come in and say, I want a boy and not a girl, and that's allowed, it is.
Mhm.
Many centers do it. How can me saying this embryo has less schizophrenia and Alzheimer's, why would that be wrong? Now, the science still is up to debate. So I've seen enough that I think that some of the models for some diseases work, but the patients have to be careful. If you don't have enough family history and genetic risk yourself, you don't really find a big difference. So, like, if you've never had someone in your family have type 1 diabetes, your risk is really low. If the dad is type 1 and his brother and another
Mhm.
person, then the
Mhm.
models start to work really well. So it requires a huge amount of counseling. The cost is really high for this, for these tests. And patients can really be misled into something that they don't need. But for someone who is worried about it, you're going to be hearing about this a lot. I think a lot of the resistance to it is people that don't understand the technology
Mhm.
or are afraid that we're going to start screening. Like, for years, I
Yes.
said, hey, we don't have to discuss this because we can't do it. So, like, when you start getting into things like height and IQ and eye color, like, I think we should focus on serious illnesses
Yes.
where we could really, that's our mission, is
Mhm.
to have healthy children.
Yes, yes. But of course, people are afraid there'll be a slippery slope because we see all the time that people, as we spoke about before, who choose donors sometimes get derailed by their anxiety and start looking for things that are appealing rather than looking for health. And that people might be inclined to do that. And that could be something that, eugenics is going to kind of take over our industry.
The donor community, I've already gotten requests from people saying, I want to pick a donor. And we'd like to screen donors for the IQ genes, and then we'd like to separate the embryos because you could get theoretically a 5, 10, or 15 point IQ boost. That's like what happened with the Ivy League donors. Now you can actually get to those genes. And as part of this test, not only do you get the screening of the embryo, but to get it, the mom and dad, sperm and egg source, get whole genome sequence. So you're screened now for 2,000 genes in yourself. And
Hmm.
so, the major genetic research company, they offered me as part of a project in 2017 to have my genome sequenced. And I did it. And I had to sign a waiver where they said, here's the panel of incurable neurological
Yes,
diseases.
that's right.
Do you
Yes,
want to know the answer?
yes.
And I had two very young kids. They were in the back seat of the car. And I said, should I sign the paper? And one of them was the empath. He's like, oh my God, no. I would just be so sad and I would be worried about
Yes.
this for that. And the other one was the scientist. And he said, well, if you have it and you're going to die, we should know about this and we should plan for it. And that means I'm going to have it. So I should know about it and plan for it. So sign the paper.
Right, right. Oh my gosh.
So when you
Yeah.
do this, instead of screening for 100 genes in you and your partner, you're screening now for 2,000.
Yes.
And we really are able to start answering questions about the health of embryos that were unfathomable 5 years ago.
Yes, yes. And it's so important. I mean, we just saw this case, right, where there's a sperm donor had many offspring and he was a carrier for this cancer gene and no
Correct.
one disclosed this, it wasn't tested and all of that. So it's so important, particularly in these situations where there's so many offspring, right? It's not just, I mean, every life is important, but it's so important, I think, that people just feel concerned about this inclination for everybody to be, a scientist and be Christy Brinkley and be talented and, all of that. And that could be problematic.
We don't screen for cancer genes routinely. We screen for things that are lethal in childhood. And I have had couples come to me and say, you know what? I do want to screen for genetic cancers. I do
Yeah,
want to look
sure.
at that. in themselves or before they have children. And
Yes.
we had that ability, but very few fertility centers. It's so complicated. Like everyone's going to have something,
Yes,
and it's
everybody.
how far.
Exactly.
I think we're at the point where things that in the past, like when I had it done, they said these are incurable. Now, everything that you find that's got a genetic basis has a potential intervention over the next 30 years. So it used to be why ask the questions? And now we can really get to early intervention. Like, if you have kids with ADHD or autism, finding out at birth, and you start an intervention versus starting when they're 8 or 10 years old. The earlier you know these things, the more you can help that individual.
Yes, the best intervention is early intervention. There's no question. Yeah, I agree with you 100%.
I mean, this is a challenge. So these are the debates: is should we even ask? So there's some people say we shouldn't even ask these questions. Don't touch anything that's not lethal. And then other people say you could do it, but I don't believe the science works. And other people say, listen, here's the cutting edge. If your family's at risk and you understand
Yes.
that and you want to reduce that risk, you have a right to have that test.
Yes, I agree with you. And I think it's very hard because for whatever reason, I think our field is so different from other fields, right? You've probably heard people say to me all the time, well, if I'm not getting pregnant, then maybe God doesn't want me to get pregnant. Maybe I'm not meant to have a baby. And we use so many things to intervene on our health on a daily basis all the time, from cancer treatment to wearing glasses or straightening our teeth. And so we intervene with nature all the time. But when people try to get pregnant, they think, well, should I even be doing this?
Right. So I put up a post yesterday where I actually said, why is it called playing God and not doing God's work? And so,
Exactly.
like, I've made videos a lot on this saying, I hear this a lot. Like, it's just not, and people in comments will say, I put up a video showing ICSI and they said, breaking the laws of nature, that shouldn't be a baby. And we said, well, listen, my dad had a heart attack, his
Yeah.
vessel closed. Did the universe say that you're supposed to die?
Right.
So I said, why is a heart organ allowed to be fixed, but a ovary uterus organ is like, there's no other organ system that has a value assigned to it the way reproduction is. And one person, a rabbi once said to me, who was a patient, gave me a gift and he said, it's said that there's two partners in every birth. We're three. There's the man, the woman, and God. And he said,
Hmm.
we believe that God chooses emissaries to give knowledge,
Hmm.
to do good. And I always say to people, don't give us the credit that we're playing God. We're not that good. Like we
Right.
can't bend the laws of nature. We
Yes.
basically just take the natural process and assist it, but we can't do anything that doesn't exist in nature. We're not that good.
Yeah. Well, listen, I wear readers to read, right? I mean, so I'm defying nature every day.
Correct. But it doesn't have the only reproduction, as you say, it has this value. And we've seen people say that, and it hurts them so much, and family members will say that to them.
Yeah, it's very upsetting for them to hear that. So I agree with you. I think everybody is entitled to build the family they want and do everything they can to have their child be healthy. And that's the most important thing, not the IQ and all of those things, but having a healthy baby. Everybody thinks their baby's cute, right? So in the end, everybody's going to love their child and everybody's going to want their children to be healthy. So
Right. As we get more of these technologies, though, it's going to become more and more confusing. Like
draw the
what
line.
happens when healthy people want to start using these things? How far do we go to
Hmm.
have the healthiest child? And we'll have to, as a field and society, answer those questions.
Yeah. Well, I suppose maybe it's time for you then to join the ethics committee at ASRM.
Yes. Yes.
Well, it's so great to have you on, Dr. Palter, and talk about all of these really important topics. And I'm glad we had your time today instead of just 60 seconds on Instagram, because it's great to really dig into some of these really important issues that people really need to start to think about. and really ponder before they move forward. They really need to think about all their options. And fortunately, there are so many, right? When I was going through IVF, there was, like a 2% success rate or something, if you're lucky. And if you transfer 4 embryos at the same time. So, we're really in a nice place in our history, and there's so much to know. So I hope people reach out to you. Do you prefer people reach out to you on your website or on social media?
The website's goldcoastivf.com for people who want to come as a patient. I'm now licensed in, I think, 44 states. We
Wow.
do licensed almost in every state. We start remotely. You can do almost your entire treatment virtually. We do testing in every state, and then you can finish up with just a few days in New York. If people want to learn from me online for free, it's at Steven Palter MD on virtually every social media platform. And if you want to do the PCOS program remotely, so if you have just questions in general, reach out on social media if you're not looking to be a patient. And the PCOS Lifestyle Reset Program is PCOS to Pregnancy. It's at PCOSbaby.com.
Terrific. Terrific. That's so much. And we will put this all in the show notes for all of you because I know it's hard to keep track of it all, but it's really important. So check it all out and take a look at what Steven Palter has to offer because he's a wonderful doctor. And as you can see, very committed to all of you out there and to your journeys. And we are as well. So if you would like more information like this and you'd like what we're doing, please support us by subscribing because we know that most of you who watch us don't actually press the subscribe button. So if you can do that, we'd really appreciate it. We really want you to be part of our community here on social media, within our community at familybuilding.net and everywhere else that you could find us. We are here to help you and support you have the family of your dreams. So we will see you next week, and thanks again. Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.